Greetings from eMedi News, Heartcare Foundation of India and Board of Medical Education, Mulchand, MedCity. Welcome to our show, Chat with Dr. KK. We have with us Dr. Rohit Aggarwal, who is Assistant Professor of Medicine, Rheumatology and Medical Director, Arthritis and Autoimmunity Center at University of Pittsburgh, United States of America. Welcome to our show.
Thank you.
What we are going to have a chat today is update on gout for family physicians. And in India, we have lots of patients coming with the metabolic syndrome. And asymptomatic hyperuricemia is very common. And people say that asymptomatic hyperuricemia is a marker for, some people say for coronary artery disease, some people will say for chronic kidney disease. And so general practitioner is always confused. Is it hyperuricemia or is it gout? So what is gout?
So the gout, hyperuricemia is a precursor for gout. Gout as is defined by having an attack of inflammatory arthritis where the crystals of the gout precipitates in the joint and causes inflammation. Hyperuricemia is not gout. Hyperuricemia is the stage before the gout actually happens. However,
if you say that hyperuricemia is a stage before gout, that means every hyperuricemia will end up into gout?
No,
if not controlled?
Not necessarily. Not necessarily, because there are other factors that controls the inflammatory response. So you can have hyperuricemia, but if you don't have, if your body is not mounting inflammatory response, it will not cause gout. But hyperuricemia itself is becoming a disease now. And what, as you rightly said, metabolic syndrome has been highly linked to hyperuricemia, and in fact there are some studies coming out which says hyperuricemia may be an independent risk factor for coronary artery disease, independent after controlling hypertension, after controlling diabetes, age, other factors that we know for coronary artery disease, because it's becoming a marker for metabolic syndrome. So nowadays there are more and more studies coming out where they're trying to treat hyperuricemia and see if we can reverse the attack. One of the recent study that came out, they took young patients and did a hyperuricemic treatment to those patients, give allopurinol, and saw that their blood pressure actually got better over the period of time. So young hypertensive blood pressure got better. Very small study, I think 10 patients. So it's not definitive right now, but more and more studies are coming up. There was one study where they tried to see if they give hyperuricemia to patients with chronic renal insufficiency who has gout. If they try to give allopurinol, does their creatinine decreases? It did not decrease, but part of the criticism was once it's already advanced stage, you're not likely to decrease it. It's more likely to have effect if you treat early. So,
let's talk about for a doctor when it comes to hyperuricemia. What are the numbers?
So hyperuricemia number above 6.
Above 6.
6 is hyperuricemia.
All over the world, or
all over the
Indians
world,
they are different?
All over the world.
So if it is above 6, if it is below 6, ignore it.
Yeah.
If it is above 6, what next?
What next is, depends on where are you, what stage are you in. So if it's 6 to 10, I would say still there is no data. 6 to 10 to 11, I would still say there is no data right now that you need to treat it. Unless until there's any indication like gout. If there's an indication like gout, then you have to treat it. But
so
just
asymptomatic
hyperuricemia, you don't treat until
up to
at
the
least
level
11.
Of 11.
There is no
up
indication.
to 11, don't treat.
Don't treat.
Even if there is CKD?
Even if there is CKD, yeah, because there is no data behind it right now. There's
even if there is an underlying coronary artery disease?
Yeah, because there's no data.
Even if the person has metabolic syndrome?
Yes, there is no data. There's no data right now.
More than 11, no clinical gout, treat it.
Treat it if you have comorbidities, because that's what you're trying to prevent.
So more than 11 comorbidity, treat it.
Treat it.
More than 11
especially
with gout,
renal insufficiency. Especially renal insufficiency, because you're 100% sure if somebody has uric acid more than 11 with renal insufficiency, if they don't have gout today, they will develop gout tomorrow. So you're sort of treating it ahead of time and also hopefully preventing the other issues with hyperuricemia.
I'll give you my personal example. I would treat a uric acid of more than 7 with CKD. I would treat. I'm not saying the data.
Right.
I would treat. If I do that, am I doing any deficiency in service, or I can still with my consent of my patient, and if I find good
can do
results.
it. You can do it with thinking that this may actually prevent the comorbidities as we talked about, but there is no hard data behind it, so I can't recommend it. And also think about this way: if you give allopurinol and patient develop syndrome, allopurinol hypersensitivity syndrome, so you have to think about the risk of that as compared to giving allopurinol for no solid evidence right now.
Okay, and if a person has hyperuricemia, do I start looking for CKD? That means if I find asymptomatic high uric acid, should I start looking for doing a treadmill, doing a renal functions?
Renal function is good enough.
Hyperinsulinemia?
Renal function is good enough, but you would also look for other metabolic syndrome things because hyperuricemia is becoming a sort of a biomarker for metabolic syndrome.
Okay, what about the diet? If a person has high uric acid, what do I recommend?
So the diet, overall, previously it was recommended low purine diet, but I don't think low purine diet means low green leafy vegetables. There is no data that green leafy vegetables increases the risk of gout. What it does is low meat, especially red meat, alcohol, obviously.
What about fermented foods?
Fermented food, like for example, your
idli, dosa, and then dokla, and dahi.
They do increase the uric acid level, but there is no association shown that they actually, if you cut down those diet, it will reduce it. So there is no evidence about that. There is evidence that they may increase uric acid a little bit, but no evidence if you cut that down.
If my patient is sensitive to allopurinol, what are the other drugs available?
So there's a new drug coming out in the market called febuxostat.
That's available in India.
That's available in India.
Practically, we have stopped using allopurinol.
I think people, whenever new drug comes on, physicians generally jump on to the new drug. I think allopurinol still has a lot of value if it's used judiciously. If it's used in the right setting, febuxostat, it can be as effective as febuxostat. See, the data of febuxostat, Uloric, is superior to allopurinol, is based on a fixed dose of allopurinol, which is 300 milligram, which we already know 300 milligram is not sufficient in more than half patients.
So you require more drug?
More allopurinol.
How much?
Generally, I would say about 400, 500 milligram. You can go up to about 800, 600 to 800 milligram. So the goal for allopurinol is start low and go slow. So you start at a lower dose. If you start at a lower dose, the risk of allopurinol hypersensitivity syndrome is almost zero. If you have normal renal function and you start at 100, and if you have a little bit abnormal renal function, you start at 50 and slowly increase every 3 to 4 weeks by 50, then the risk of allopurinol hypersensitivity is almost negligible. There's a new recent study that has shown that now, but the goal of increasing every 4 weeks is uric acid. So you have to get your uric acid less than 6. So that's your goal. Your goal is not, you keep increasing until you achieve your uric acid level less than 6. So I go generally up to 600 milligram and then I stop that, allopurinol is not going to work because uric acid level is still above 6 and my goal is that. And then I switch to febuxostat or Uloric. So still allopurinol, I think that's still my first line.
My last question is that there has been an undergraduate teaching to us that women don't get gout.
That's wrong.
Is it true? It's wrong.
Wrong. Completely wrong.
Then what's the?
Actually, women get worse form of gout postmenopausal, and their gout is not as predictable as a male gout, which will start with podagra and then with few years.
Will that happen before menopause?
Generally not. Generally
so up to menopause, women will not get gout. That means if a 34-year-old female comes to us with a uric acid of 7, 8 or 9, it's not. Look for a metabolic syndrome.
Yes.
Don't look for a secondary cause.
Secondary causes. Another thing I want to point out is the new studies coming out where cherry extract has been shown to decrease the risk of gout. So a lot of people are going, if we talk about food, that's the food that you want to go for. Milk decreases the risk of gout. Green leafy vegetable has no impact on gout.
Can gout present, can you have a tophi without symptoms or without any other thing? Just asymptomatic?
Often.
Quite often.
Yeah. And that happens is because patient basically ignored the attack. They might have had milder attack.
Okay. I'm going to end by saying is that do we need to get uric acid as a part of your executive health checkup if you're going for an annual checkup?
I think yes.
I think yes.
Yes.
So
but the thing, it's the data behind it is coming up. And it's not definite, but more and more data looks that this is a marker for metabolic syndrome. We should go for
So what Rohit says is that when you're going for an annual checkup, go for uric acid also. When you're going for urea and creatinine, add uric acid to it. It's a myth that women don't get a gout. Of course, they can get postmenopausal state. Before menopause, it's rare to get a gout. And another important thing is, don't treat uric acid unless it is more than 11. If it is more than 11, it can be asymptomatic or symptomatic. If with gout, it needs treatment. And what he feels is allopurinol is still the drug of choice, and if you're worried about the hypersensitivity, go slow and go low. And that's what he says. Let's thank Rohit for being with us. That's all for today. We'll come back with one more show. Till that, goodbye. Thank you.